All right. And we had a lot of discussion last week. So just to kind of very briefly summarize, we started talking about exploration of funding for additional programs. I did reach out to Jessica, and she mentioned that the American Heart Association grant was more of a federal. Um, I might be botching this. We were not eligible, right?
No, sorry, no, what, honestly, like, I know them well, to be honest, like with the American Heart Association right now, a lot of the money was more what I've heard, even though I know American Heart Association, I am, but it's more national has been like, so it hasn't been necessarily, it's not federal, it is within the American Heart Association, but I haven't heard as far as it funneling to any of the local markets as of yet. Now, I'm hoping that's something that's going to be happening. We haven't been notified as far as I know, as far, but I know that that is, we do, that is a huge emphasis or a priority that we have nationally as far as food is medicine with our national office. And our hopes is that, okay, if it's a priority nationally, then we need to make sure that we're making local impact. But what the local impact and how that money is going to be, if it's going to be funneled down, is kind of TBD. So, I have not heard anything that it's been granted to anybody as of yet, even on a national level. So yeah, definitely not federal, because if the money, if it's within the American Heart Association, it would not be federal funding. It would be within our nonprofit structure. But as soon as I hear anything, don't worry, I definitely will let this group know. But as far as I know, the money has not been granted out to any organization, or any work has not really started as of yet.
Thank you. I'm glad that you were on to explain that better than me.
No worries.
And then we also kind of talked about exploring more the Medicaid 1115 waiver. Um, Kind of the takeaway of the initial discussions I've started having is that that can be quite the process. Not that that's something to deter us, but I haven't been able to get much farther than that. If anyone else has, feel free to jump in.
Hi everybody, sorry for being late, but I did put a question out to our community affairs liaison, and not, that's wrong, government affairs liaison, to ask a few questions about where to start. And supposedly he's getting back to me. I will send him another follow-up, because in between I went on vacation. So I will send him another follow-up to find out if he has any information on where we can start. And we also had a little bit of conversation about this in another meeting. I can't remember which one of these HEAL meetings that was, about the same topic. So it seems like it's something of interest to many, many different groups.
Yeah.
But I will follow up with him and get the information.
Yeah, I think that was the integrated health work group where we were talking about expansion of community health worker services on coverage under Medicaid. Excellent. And then the other thing we kind of talked about was the idea of expansion of IT services and utilization of an app for the program, or a possible partnership with DSS on their resource mapping and dashboard, where there's ongoing planning for that service. I have plans to follow up with Patrick Callahan on the GIS work he's doing for healthy food priority areas. So we can see if we can either bring him into one of these calls to chat a little bit more, maybe next month. Down so I don't forget. Okay. Any updates on Prince George's Fresh pilot?
No, we're still working on the coding part. So right now we have so Scarlett as well as another consultant on our program, Natalia, are working on coding of all of the participant advisory board meetings. And now they're moving on to coding the qualitative data for the surveys, for the post-intervention surveys. And we have someone working on the data to compare the pre and the post. So I've also been in touch with La Clinica, the Pueblo, asking them if they can share with us their patient data. So I'm going to have to, I visited their office twice now in the past 2 weeks, so I'll try them again, as we really do need that data to help with the pilot. So we hope to have the whole thing wrapped up by August 30, like by the end of August. Hopefully that can also include the biomarkers as part of the data. If not, we'll just have to move on with the pre and the post survey data and look at the themes that emerged through the meetings and looking at the survey feedback. But yeah, July is our final month for the last 6 people that are part of the program.
Question. So will those 6 people be on a list, or the list is already done? Did I misunderstand?
There's just one more list that Scarlett is, I think she's sent to you, or Natalia sent to you. And they've already sent the list of those that have to be removed by the end of
Okay.
June.
Oh, because she,
The ma-
okay.
yeah, the
Maybe I
majority of folks.
I think I misunderstood her team's message. So I'm glad you said something.
Okay. Yeah,
She was
so
like, oh, we don't need to submit anything. And I'm like, oh, there's 6 that need to be submitted. So I have to submit them.
okay.
Okay. I will do that because I'm in the process of doing that right now as we speak.
Oh, okay. So those 6, they will continue to the end of July, and then that'll be the end of it. And everyone else will end by the end of June.
Got you. Cool beans. Thank you. That's
Yeah.
not what her
Yes.
message says. Okay.
Yeah, no, I think there was just a minor confusion, but we spoke about it, and I think she either was going to clarify that to you, but I'm also happy to send an email.
Yeah, no problem. As long as the list is updated with the folks that you want, then I can go forward. So I'm looking right now. I'm looking right now
Okay.
because I was not going to include you guys in any submissions. So that's cool. Easy peasy, not a big deal.
Cool.
Okay.
Thanks, Leslie.
Yeah, no
I'm
problem.
glad we could fix that.
Yes.
Any other updates for Prince George's Fresh?
No, just beyond just slugging through the data.
Oh. Sounds fun.
Yeah, that's all we have right now, folks.
Thank you so much. Well, I know it feels like the theme of the summer is strategic planning, and rebuilding our new work plan, for HEAL as a whole. So I pulled out, some of the previous goals from the work plan that were directed at this Prince George's Fresh effort, but also started to draft a goal that I think captures what we're working towards in the future. So I drafted something and wanted to just throw it out and see, give everyone the opportunity to provide live feedback. And I'm going to close this so that we can see the entire screen, and then I can make some live edits. Okay. So the previous goal was to address metabolic syndrome and behavioral health by increasing access to and support of healthy living programs and resources within the county. I'm completely happy to maintain that goal, and keep it as that, if that's what everyone wants to do. I just put up this goal, which was a little bit more specific to some of the drivers focusing on HEAL, or, you know, of maintaining the HEAL work group. So improve the health outcomes of individuals with chronic disease and diabetes by implementing and promoting community-based interventions. So kind of first thinking about, do you think this goal captures what we're working towards within Prince George's Fresh and the FAM group as a whole? And let me pull up the previous goal as a reference.
What was your question?
So the question is, it's okay. So the question is, we're kind of in the state of like reworking all of the goals and strategies for the work plan. The previous goal was this top one in the italics. So I'm just trying to help us, guide us into really, you know, specific goals that represent the work that everyone's doing. And then from here, what we'll do is define, you know, which objectives we feel like address that goal or will help capture that goal, and then fill in new action steps. So what are we going to do next with this program? Pretty much where I want this conversation to go. So thinking of that goal of, you know, improving the health outcomes, like, does that feel like an accurate representation of what we're trying to do with this program?
Kimberly, where did the 5%, I'm just curious, where did the 5% come from?
Space. So that is, it's all up for discussion. I just kind of wanted to put in numbers to give us context of how specific I would like our goals to be, our objectives to be, so that we can monitor this over time. So previously, the community health improvement plan was a lot less formal. It was really like just the representation of the work plans as a whole. Now we've been asked to do a lot more collection of outcome measures and just monitoring these over time. So we'll pool all of the work plans together to create this community health improvement plan, which will then be, it's a 3-year plan, but we'll do an annual update to just see what is the status of the work. And we understand that the food is medicine work group is not the only thing impacting the health outcomes in the county, but that's kind of like just the long-term goal. That's why and then from there, we also have the short-term objectives, which would be a lot more specific to this program, if that makes sense.
Yeah, that does.
But yeah, 5% was just selection. And it was just a way for me to use the data that we have to measure these objectives.
I'll
So
just say that, oh, go ahead.
ahead. No, you go. You go.
I was just saying my knee-jerk reaction with the 5%, it just seemed really ambitious.
That is fine. We can certainly, there's no requirement to make it one thing or the other. So we can make it more I think specifically for the heart disease mortality rate, it's very ambitious because of just that was, yeah. Does anyone have a suggestion for something more realistic?
I think it's very interesting because as Michelle and her team tries to gather this information and tries to get some real numbers, I'm sure they can really say, how are you even gonna, it's hard to get the information so that we can even know if we met the number. um, we we may be a little jaded right now for goals and
So
I mean,
and
just we may all feel a little certain way about goals and objectives because real life sometimes gets in the way and impacts the look and feel, all the feels that go along with this type of information. So when I read this, I have to step back a little bit and readjust my attitude a little bit.
no, you don't at all.
You know, I'm always going to tell you what I really think. So, because, you know, this is hard work. It's good work. And I just got out of another call that was all about, you know, when do we stop trying to justify that healthy eating can help people and we need these exact numbers. And it makes it hard. It makes it hard.
I should
So,
emphasize that these numbers are not like these are numbers and data that we're collecting in the community health assessment as a whole county. So it's
okay.
not going to be specific to the participants in the program. This is just our like community health improvement plan as a county, where would we like this to see this go? So it's really like we could just casually say we want the mortality rate to decrease, but this just gives it something to look towards, like a number to kind of look towards, and we can see, I don't know, it makes it a little more tangible. So it's not, the expectation is not to see, you know, to track and do like a study of these specific patients or anything like that.
Okay.
Or participants, not patients.
I could see the long-term objective, you know, looking at the whole HEAL work group, because you're looking at the food resource map. I know that was something I remember working on with Patrick and the group years ago. So I could see that. I know there's some other pieces that are probably at play, maybe some other work groups. I could see that all collectively, you know, we could have that impact. I guess the number, I don't know if this is reasonable, but maybe 2%, you know, just because it's really, I don't know, I'm just struggling with the 5%. I don't know how much we comprise of
the total.
of all the total of things that impact people's lives. Like, we are a piece. How much territory do we have in this space, amongst where we can have the greatest impact, is like, I'm just struggling to wrap my head around. But I do understand you, Kim. I don't know if it's Kim or Kimberly, your preference, but I do understand you of how you have to have metrics. We are all held to these metrics.
Yep.
Yeah. And we definitely don't want to make this like a situation where not hitting that goal is viewed as a failure by any means. I think when we get into like short-term objectives, it's more of like well, why didn't we meet it? But this is like these long-term objectives, there's a million reasons why we didn't meet it, but it's with everything else, public health, we didn't get there, but it would have been much worse if we did nothing.
And I just want to add, like, I agree and disagree with some points. I'm for metrics because it gives you, like you said, that tangible, you know, outlook for what you're working towards. And I agree with Michelle, 2% is a good number, but like we can have that as a goal and still put 5%, because if we exceed it, it's, you know, a super win. I know it is hard to achieve it, but having like the minimum as 2% and 5 as like that ultimate long-term goal. Because in the end, that's what we're striving to work towards. And I know sometimes I can be in my mindset a little bit, kind of ambitious in that aspect, but I think that is the long term at the end.
Thank you. I appreciate that. I think I may have been in my ambitious, public health heart when I wrote this too. And I do also agree that these would be like very much a collective HEAL work group objectives.
I was just curious, since we're talking about evaluation, just putting you out there, Leslie. You're doing so much work with food as medicine programs throughout Maryland. Is that you or another team at Giant that's measuring the collective impact of what you all are doing? Because I know that you can see data from a different angle than how we can see it.
So when you say collective impact, what do you mean?
Because I know you're at different hospitals, you're in
Yeah.
different locations,
So there are also different groups of people. So when we individuals, I don't dictate what your program looks like. So some of the folks are hodgepodge like yours. You have people from DPP and then doctor's offices. But then there's some groups that are just DPPs. And then there are some groups that are in a already kind of contained cohort where they are coming from one part of a program and stepping into another part of the program. So it really depends on the objective of each organization. But I could say overall that X amount of people are purchasing X number of fruits and vegetables, fresh and frozen, and that these types of programs are indeed showing that people are willing to participate and purchase these types of foods. I could also speak to the variety of foods people purchase. Yeah. So, but as far as the metrics for each individual and the end results that each organization is looking for, that would be up to each organization.
Okay.
Too, that is a piece of why it makes this challenging, because we have a little bit over here and a little bit over there. And, there's no meeting in the middle, except to say fruits and vegetables are good for you. We all come back to the same. So
Yeah. Gotcha.
But yeah,
Thank you.
that's what I could contribute in general.
I have a question about the metrics, I guess more from like a learning point of view. But I was just thinking with a little bit of what Leslie said, is there kind of like a why behind that, like a certain number, like why 2% or why 5%? Because I'm thinking in the case of Prince George's Fresh, for example, we're trying to measure the impact of a population that's has higher incidence of chronic disease, right? So are we trying to compare that with maybe neighborhoods or communities that are not under-resourced and what the rates of, let's say, heart disease are in those areas? Or where is there any kind of like point of comparison that gives more context to these metrics and goals?
Great question. So yeah, so we typically do comparisons to just the statewide average. So I could pull, those numbers in and say, like, I know right now our mortality rate for heart disease and I believe diabetes is greater than the state. So maybe our goal could be to just get closer to where the state is. And I can find that out before we, finalize any of these. as well. I think, actually, yeah, let me locate that really quick for the.
Hi everyone, sorry for jumping on late. I was in the train.
Hey, Taryn. Good to see you.
Good to see you
Yeah.
too.
Isabel, that was a really good point. And now I'm thinking of other things.
I had thought this was with the 2030. Can't remember the proper term right now.
Healthy people.
Healthy. Mhm.
Thank you. I was gonna say the Millennial Development Goals, but yeah.
You mean like their specific goals, the Healthy People 2030 goals?
Yeah, because I know that they have some benchmarks to reach. So I thought that this was in comparison to that. Like, but now that you said it's the state, okay.
So the state, the heart disease mortality rate is 163.2. So if we tried to decrease by 2% of our current rate, we'd be around 166.4. So we'd be closer, but not as low as the state. So more realistic.
Yeah.
Yeah. But thank you. That helps put it into context too. So
I should also add, these are 2019 data. I can look to see if we have something more updated before we finalize these. But the data just weren't available yet. And similarly to diabetes, Maryland's mortality rate is 21.4 compared to ours at 28.0. So 5% there doesn't take us as far. And then inpatient hospitalization, I don't know if I have the state right there, but I could probably get it. Or if we feel that that's less relevant as one that we need to track in terms of an outcome, we don't have to.
I think that the hospitalizations are pretty important because that speaks to the healthcare Medicaid piece that yeah.
Yeah. I think it's relevant because the other piece that we want to influence with people is not just to take up more produce, but we want them to be connected to a healthcare provider. So that's also a goal, is that we want them to be in touch with their provider, and hopefully by so that could prevent them from having a hospitalization.
Excellent.
I get too much into the weeds, but for the mortality rate associated with heart disease, I don't know how to phrase this, but I don't know how to phrase this question. But given that, when you reach a certain age, heart disease can become inevitable. So, sorry, is this like otherwise preventable heart disease, or is that an irrelevant question? Like, is it already taken in consideration that as we age, like, you know what I mean? Like, we're trying to have that intervention with otherwise avoidable death.
So would you want the stipulation where it says reduce the mortality rate associated with type of heart disease, or is that where the clarification would be?
I'm not really sure. I'm just bringing it up. I think those in this group chat, this group, you all may be better informed than I am. I don't know the
I
phrasing.
think it
I'm just bringing it.
I think it also depends on how these statistics are derived. So, for example, if it's saying 169.8 per 100,000, like what is, like where is that actual, what is what is that exactly defining? Like, is that 169.8 per 100,000 of individuals until the age of 85? Like, what is that what exactly is that population definition? So I think that would be helpful. If I see what you're trying, yeah, I see what you're trying to say. I think that if we would just have like the parameters around what that population definition is, because yeah, I mean, obviously, we're trying to prevent heart disease at any age, but yeah, I think it'd be
Yes.
what the definition is there.
Right. Right. I would assume it's age adjusted, but it's been so long since I took epidemiology, I don't even remember what the right metric is or how to describe it. So I think we have some folks that just graduated, so maybe they're maybe you all are fresher in this. It's been more than 10 years, guys. I don't remember. Anyways, I think you know what I mean.
I hear what you're saying. And then in terms of the data, I believe this specific data point is just the total population. And it's not age adjusted, but we do have, I think we have the capacity to look at a certain age range. We also have obviously more data around specific populations that are more impacted. But I guess that kind of comes to the next point, which is it depends on what direction we want to take the next steps. If there's going to be a focus population, then we need to get more data on that focus population. And if we kind of go through this data in the the community health assessment, and see like one, population is specifically impacted, maybe we can find a way, but I don't know. What is everyone's thoughts?
Hello, this is Benji here. So I was looking at the right now, actually, at least on the slide for heart disease, and it is age adjusted. So there isn't or at least not where I'm looking, there isn't a distinguishing component between age. So if we wanted to specify something, we might need to get into some more like raw data as opposed to the health assessment itself.
Okay.
What was your question, Kim?
I guess just where does everyone see the next steps going? I know a lot of this is dependent on if the grant works out or if we can identify other funding resources. And maybe some of that, Michelle, we can like go through some of the specifics that I don't know if there's more of a vision there for what the next steps would be for implementation. But or if it's also dependent on just like the finalization of the evaluation for the current program.
Okay.
Definitely our goal is finalizing the evaluation by the end of August. We anticipated it being completed much earlier, but to give us space, we'll say the end of August for now, because we should be for sure done. question for the group. So with this evaluation, one of the things that I'm floating around is that, is it worthwhile to, and I'm not experienced in this, is it worthwhile to share this with our council members in some way, or their staff, so that they can be aware that this exists and what we've learned, try to get the gears in motion?
I like that idea.
I don't have relationships with anyone though. Just-
We could work through the FEC, I believe, with our relationships. Yeah.
Oh, that's where the other conversation was about Medicare, was FEC, I think. So,
Mhm.
but yeah,
Mhm.
I think that would be a good idea. And then, I'm on the board of Prince George's County Chamber. I don't know if that helps. I'm still learning what that really means, so forgive me if that means something.
The Chamber
Um,
of Commerce.
Yes. So many times they will have a lot of the council folks come on board. And they have there's a healthcare committee. And sometimes there are members of the council will attend. So that could be a way in. I don't know. Again, I've only been on it for like 4 or 5 months, so I'm still feeling my way through what that really means. So, yeah. So I
I
could
think that
ask.
could build support for this notion. I mean, we're a small program, and that was all we could manage. But if we want to have an impact, I can't see any other way than expanding the program.
Mm-hmm.
And we need a bigger base of support. So yeah, I could see the FEC, they already have a lot of inroads there.
Yes.
And whoever else wants to hear about it, we could tag along.
Mhm. And then the
Mhm.
Medicaid piece and the potential to expand this beyond Prince George. I'm sure they'll eat that up as well.
Definitely.
Is it, to tag along with that, is it worthwhile for us to find out the priorities of other advocacy groups? So we have FEC. It's embarrassing that that's part of it. It's part of IPHI, but I actually don't know what is on their agenda with any policy or advocacy, because I know that we're also replacing Sydney, and we haven't had a replacement yet. But also with Maryland Hunger Solutions, are there any other groups that are advocating for these types of programs or something similar?
Well,
Hmm.
I mean,
know.
it would depend on under what context. I think what makes IPHI and Prince George's Fresh special is that you are acting as a conduit and an administrative leg to support patients from other practices or programs. Whereas some of the other programs that I work on, it's all healthcare. It's direct healthcare. It's not a nonprofit doing the work. It's an actual healthcare provider, or like a LifeBridge Health. They're doing their own program. So you guys are different because you're able to take a little bit from a lot of people and kind of put it together in one program. That makes Prince George's Fresh unique, and it's geographically centered. It's region centered just right now, at least for Prince George's County. Whereas, some of the others don't care. They just want the people to take part of the program. So it's interesting. I don't know.
Mm-hmm. Yeah. I'm just curious about the advocacy part, because maybe there's other groups that might be interested in pushing for this, and then we can bring them in, or we could join their efforts. I don't think anyone's pushing for this specifically, but there might be parts of it, of what they're pushing for, that would align with us. I know that Maryland Hunger Solutions is doing something around expanding SNAP benefits, but I can't remember what it was. So
Yeah,
just a
yeah,
question.
there's similar programs in like Baltimore City where they're expanding the way SNAP benefits and a quote unquote food as medicine benefit is given to SNAP participants.
Okay.
So right now we offer, if you're online SNAP, a $15 benefit twice a month. So that's one of the ways that SNAP is, even though SNAP could be considered a food as medicine program, even though it's the whole grocery store, you could easily say SNAP is a food benefit, food as medicine kind of programming. But then within that, you can stack additional programs on top of SNAP.
Yeah.
I'd be careful to identify SNAP as food as medicine. I think the concepts are different. I understand what you're saying.
Yeah.
But yeah, I think the concepts behind them are different. And I think for us
sure.
to remember, as we're looking for partners and to expand the reasoning why we did Prince George's Fresh the way we did, so that those who are undocumented are able to participate.
Exactly. No, true.
Yeah.
Very true. No. I would not include SNAP as a true food as medicine program, because it includes the entire grocery store and you could buy so many different things that probably would be considered quote unquote food as medicine or healthy food items. But yeah, there's in some ways pushes for SNAP and WIC to be kind of considered a way to ease of way to get people access to food as far as nutrition security and insecurity.
Yeah.
But for Prince George's Fresh, I think the way that we have it structured, no matter how people get those fruits and vegetables, fresh, frozen, what have you, is a beneficial way to still communicate that food as medicine piece. But you guys have access to so many different organizations. Is there a way to branch out? Because like I know the Mary Center, they want to do it. There's other organizations that want to do it. And are they able to, in structuring programming, are we able to tap into their funding? Is it a way that we can restructure? We can say, okay, you have funding, you want to be in this program, we administer it for you, but you have to bring in a piece of the pie to help get it done. That's kind of what Baltimore City is doing for SNAP folks, to encourage more SNAP usage. They're saying, hey, we're going to give you X amount of dollars so that you'll participate in SNAP and you'll utilize it. So here's an incentive. And so Baltimore City is funding that as far as SNAP. But if Mary Center is interested, I know they got some funds. It's budget time. Can they write a line item for food as medicine and then participate in the program with X amount of people? I don't know. That's a,
Do we know of any other food as medicine programs that are happening within Prince George's County?
I know that
Um,
CCI is starting theirs.
They are. Okay.
and I think TLCMD, they want to do something as well with Giant.
So they're currently in contract now, similar to, but their focus again is different. It's DPP. It's not going to include. It's not going to be like Prince George's Fresh, where the beauty is we don't care. We just want you to get the good, healthy food, nutrition security. But TLC is going through the DPP kind of route where you have to be in a DPP program, diabetes prevention program, for those that don't know. So that's the route they're going. And some of their DMSE programming. So you have to have insurance, you need to go to, the hospital, blah, blah, blah.
I mean, those are both partners that we regularly work with. So even if we didn't have, if they were not funneling or sending their referrals to our program, if we could collaborate on some kind of evaluation or just support for food as medicine as a whole, it could be just another step for collaboration. But yeah.
It could make for a very interesting study.
I think we brought up before, and I'm not sure where we are in that, but one idea was to have a summit or a meeting of just lessons learned overall. And I don't know if we wanted to still do that or not.
No, we do. It's just because I've been threatening to introduce you to LifeBridge folks for years. I just have not been able to. Gotta do it. Let's just do it. I'm gonna do it right now. Let's do it.
No, don't do it.
No, don't do it.
Yeah, don't do it yet. I've been told just to hold off on taking on any projects until we've completed our evaluation. So it's not that we don't, but we want to wait until we get our, and then we want to see what's next. I'm just sorry, Kim. I don't mean to take over your meeting. I was just thinking of some items that are like low hanging fruit that we could, achieve by the end of the year is all I was thinking. So please, if I'm derailing it, like intervene.
No, this is meant to be collaborative, and that's why I put a blank screen up and had everyone fill it for us. It's just wanted to do it together. So I think, yeah, a summit. I mean, I hate to keep being like the person to be like dates and times, but if that was something that we wanted to do, what do you think would be a realistic goal? Like, would that be 6 months after evaluation? Does that take longer? I've never done a summit before.
So the evaluation finishes August. We'd have to think who we want to invite, where. So how long would it take for us to do that, and budget if possible? So, and then to August, September, October, November, we don't want to hold something in December. But maybe 6 months would do. January, February, 5 to 6 months.
Well, February is Heart Healthy Month. It could be a thing that we could have hospitals and the MCO sponsor in support of Heart Healthy Month, and it could be a lessons learned across the county, what's working, what's not working, and Leslie will be on the panel because you do everyone's stuff. I don't know.
Help me.
You know, we could have our
Mhm.
participant advisory board members if we have funding to support their time. Like, those are some features we could have.
That sounds fun.
Mhm.
And Anthony will just give us a place to have it through Parks and Rec.
I mean,
He's not on, so we're allowed to say that.
Yay, Anthony.
I guess depending on how big it gets. But they've got they've got the that whole place where they do graduations.
Oh, oh boy. So it sounds like a lot of the earliest focus is just around building support presentation of the results of the pilot and exploring partners for what could be part 2. So I think with that, this will probably turn into a few different strategies around those topics. Just, I mean, and it's all just a reflection of building support throughout the county for this data-driven, evidence-based process of food as medicine. Mhm. So is what are we moving toward trying to say Prince George's Fresh is something that is available in Prince George's County, and then when someone says Prince George's Fresh, they go, oh yeah, that program where you get fresh fruits and is that kind of where we want to see this? Or do we just want to see it as, hey, it was a pilot, we got some information out of it? Or is it something that we want people to know and recognize when, I don't know what I'm trying to say, but I'm just.
no one
I
recognized.
get, yeah, I get what you're saying. Like, do you want it to be faded or like a continuation or,
Yeah, because that really that will determine our next steps. If we want to make it, because this is how it all started, right? Some people on a call talking about it and trying to make it happen. And then somehow we boondoggled our way into making it happen. And now we're here. It happened. So are we happy that it happened? Whoop, whoop. Or do we want it to go and be more?
Go and be more.
Go and be more.
Yeah, I mean, what the preliminary results were that 6 months wasn't long enough and people needed more for their household size. I mean, if you ask me in Scarlett, we're going to say we just want to expand it for maybe a longer term if that was possible for more people, and we'd want it in a larger section of the county. Like, I think if it was up to me and Scarlett, like, we're all about expansion, but I don't want to speak for the group. But then it also just like we'll have to, get that money to make that happen.
You have to get the money.
Hmm.
So that's why I can't say
a
like
cheap
this is
program. It's not cheap.
not a cheap program because it's not a food distribution program. There's so much more to it, which is why it's expensive.
Mhm. I did a presentation last week for my division, like our monthly meeting. Someone picks an article and they talk about it and how it relates to healthcare. So I did, of course, food is medicine. So I give some of the preliminary results from Prince George's Fresh and another article that they did. Article was about tying in food as medicine programs and specifically the medically tailored meals on how that affects different chronic diseases, and one actually helped reduce the length of stay in hospitals. So that's something I know all hospital systems are interested in right now because length of stay is too long, even though I think it's the new normal. So you know, they were interested in that. Like they want to know more.
Mhm.
So right now, you know, Physician Enterprise Division of Adventist Healthcare is peaked. Like
Mm.
they want to know more
So-
about this food as medicine and what we could do with it.
So another part of this is we're exploring, and some of you on the call already know, but we just had a chat with Jessica yesterday. We are exploring the medically tailored meals to have them available for purchase. So that could be another piece, depending on, you know, how we implement it. We are in the fact finding stage right now to even see if people would even consider you know, this type of programming basically from the grocery store. So it's how can I get for my program participants, you know, is it the care out after leaving the hospital? Is it pharmacy to at bedside where you say, hey, you're going to need X amount of standard drug intervention, and here's you know, 6 months worth of meals to go along with that. So what does that look like? How does that feel? What, you know, I don't know. We're still trying to look at it and see. And it could be a piece, a new piece of Prince George's Fresh if we decide to do it. I mean, I can't say because right now we're just talking about it and looking at it as a way to provide another phase, another piece of the food as medicine puzzle.
And that would be Giant would be preparing the meals.
No, we would we'd have a vendor that's preparing the meals. So right now I've tasted meals from multiple vendors, and it's you know, more about you know, cost, price point, different pieces of that. What does it look like? How fancy should it be? Is it basic meals? Do we want to upscale the meals? You know, there are different considerations to that.
Yeah, I read a second article from a doctor out in Cali who does you know, food as medicine she prescribes for her patients, and she was going through and saying that it's not as easy as basically what you're alluding to. It's not as easy because, you know, some vendors, the quality of the food, where are they getting it from, you know, the freshness of it and things like that. So
Yep.
they seen the most success with it coming from local when they're sourced locally. And also some of the vendors, because they see that there is money in the food as medicine
Yes.
business, they hop over. So they used to do weight loss meals and different things, but now that they see the money's here, they're hopping over and not necessarily, you know, providing the nutritional benefit that they should.
So we
So,
found a vendor that's
yeah.
local, that utilizes local chefs, and whenever you tack on that word local now, it's like a boutique kind of thing. So then the price goes up, right? So you have to find your space, and you know, well, we're doing local fresh food, but sometimes your clientele, either one, their insurance doesn't allow for it, and we're in Maryland and Medicaid, blah, 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 blah. And then you may not be able to afford it because you may not have a flexible spending or a healthy savings benefit on your insurance. So there's a lot to consider when you're thinking about it and making sure, but it could be a piece of our food as medicine programming, to, no matter where it comes from, to look at medically tailored meals as an offshoot of any other type of program that we would be doing. So even if it's, you know, Food and Friends providing that type of medically tailored meal that they're already established, so they could become a partner. So there are different ways we could work through that. Meals on Wheels, they already are established and they're providing meals. So, you know, there are different ways we could partner, even if it's not Giant, but there are different organizations that we can partner with to kind of create that medically tailored meal environment for our participants.
Yeah, I was going to suggest Food as Friends if you had, if Giant had spoken with them, because I know they're big in this area.
Oh yeah, we do volunteer with them from time to time, and we provide them with food, and so that they can make the meals, specifically like turkeys at Thanksgiving and all the fixings and trimmings, so that they can make the meals and send it out to their members and participants. A lot here we could do. All right. I don't know if we filled out all your form.
No, this was a really good discussion. I think it gave me a lot better understanding of kind of where things are and where you all see them going and what is still up in the air. So that is super helpful.
Yeah.
Thanks. Yeah.
Oh, and can I just say one thing that has nothing to do with this, but has everything to do with Prince George's Fresh? There's no spreadsheet with people's names on it in the Teams channel. Can you please add the names to the July spreadsheet so that I can make sure they get what they need?
Sounds good. I'll work on
Thank
that.
you. I put a
Leslie.
spreadsheet in there in the master so you can add the folks.
Okay, sounds
Okay,
good.
thank
And
you.
I just wanted to say one last thing, Kim, is that, with our participant advisory group, is it all right if they contact you? Like, we could offer the opportunity for them to participate in the HEAL work group meetings, as I think those are open to the public. Would that be appropriate? And if so, would there be space for some level setting or explaining what some key terms are in case they may be, that they're just coming in, so that they could participate fully in the meetings? Just, I know we're at time, but I wanted to bring that up. If you have any hesitations around that, then I won't let them know about that. But I thought it could be a good opportunity since we're wrapping with this work.
Yeah, I think that's great. The next meeting I think is August 2nd, and our goal is to kind of have a bit bigger piece of this, plan for the HEAL group moving forward put together and to present those pieces. So it would be a good time for them to join because they can kind of see some of the work that's up and coming.
Okay. All right. And then the only other thing I wanted to add with what we were talking about with came about because there were folks that were not able to get the benefit during a really uh, intense time in our history. So now that that period is sort of, we're living in post COVID, what are the going back to the numbers, would it be helpful, or is this too much in the weeds, of a population that we should target who's not being served? Would it, you know, is maybe if you all have any data around that, that could also help shape our goals. If we see any trends, I mean, everyone who's working in the community, if they see anything or want to direct it like that, that could also shape what our future activities are, going back to prevention. Do we want to intervene on a younger population or just keep it open, or specifically for those that are not eligible for SNAP due to,
Yes.
I don't know, again, throwing a wrench in your
No.
machine.
No. There are so many people that are kind of like working, and there's a new name for it. They have an acronym for everything. Is it the ALICE population? I want to say the folks that are working but still can't seem to make those ends meet, but they maybe don't qualify for SNAP, but they still struggle from month to month to
Yeah.
get what they need.
Oh, the able-bodied, I think. Oh,
Yes.
there we go. Asset limited. Mhm.
Yep. The ALICE population. They got an acronym for everything. But
Maybe
yeah.
if we think about that, because that also affects what our activities entail.
Mm-hmm. Yep. And those seniors too that
Yeah.
don't necessarily, they qualify, but they don't qualify.
I
They
think
do,
seniors are
but only for a little bit.
because they have a really low income. I mean, when I when I used to talk to food banks, the primary folks that were going there were seniors. And then they have other issues with the transportation and the challenges with carrying the groceries. But, and they could really use the medically tailored meals because not everyone's able to cook.
Yep.
And they're not aware, or maybe not, there's just barriers in them accessing SNAP.
Yep.
Maybe awareness, education. So I could definitely see them as another one. And going after Medicare, they could fund it. I mean, we have a lot of folks in our program that use Medicare. I brought that up before.
And
Yes.
just to add, we've had a couple senior folks
Yeah.
reach out to us, just to seek resources. So we do have the need there. So yeah, that could be a good population to serve.
Okay.
Excellent. Yeah, I can start reaching out internally and see what kind of data we can pull. Hopefully we can get something by next month.
All right.
Well, thank you guys, and apologies for us going over. This was great though. I hope you all enjoy the rest of your day and week.
Thank you.
Thank you.
Thank you.
Thank
Nice
you. Bye, everyone.
conversation.
Bye-bye.
Bye.
Have a good day, everybody.